Do come in and take your seats. Come on in, guys. Let's get this session started. So welcome to what promises to be one of the most fun parts of this conference. And I'm so looking forward to listening to these incredible talks that we've got. Although we all know echocardiography is about getting accurate information, actually what we love is a pretty picture. And there's no getting away from that. I'm Claire Colborne, I'm the IPP, and this is my colleague, Tom Ingram.
Yes, good morning, everyone, and I'm delighted to see so many people have made it here on a Saturday morning in Bournemouth. When I looked at the programme and realised I had the privilege of chairing this session, it made me think, wow, that's like Christmas. Now, bear with me, I know that's a bit superlative, but...
I'm going to tell a story.
I was thinking, it's like you've had your presents and someone's passed you the box of chocolates and you're the first one to open it and all of the best chocolates are there and you just get to sit down and choose your best one, or your best 5 in this case. So let's get started with what I think will be the Malteser of the celebration.
I think it's actually a chocolate orange, but there we are. Sanjeev, you are a chocolate orange. May I introduce our first speaker. This is Dr. Sanjeev Bhattacharyya, who's well known to everybody in the echo world as one of the consultant cardiologists who values echo so highly that he doesn't bother with any other modality, and we love him for that. Sanjeev, take it away.
Thanks very much for the invitation. I'm going to be talking about tumours and the heart. So if we think about, we don't really see a tumour, we tend to see a mass. We need a diagnostic approach to this. And we can use the clinical history, location, response to therapy to give us some clues about what something is. So obviously thrombus might be an area to alter blood flow, as often post-myocardial infarction. There may be prosthetic material, and it may respond to anticoagulation. Tumour, they may have a history of malignancy, and it may be an artifact if it's only possible in a single view, or it may be a normal finding. And we can use the whole set of tools that we have at Echo to help work out what a particular mass is. So we can use 2D to look at the size, shape, location. We can use Doppler to look at, see if there's any inflow or outflow obstruction. 3D to look at attachments, and contrast to look at vascularity. So we need to use all our tools in Echo to help us work out what a particular mass is. And the first thing to say is just we need to make sure it's not a normal variant. And there's a whole load of these. But the most common are probably things like crista terminalis, eustachian valve, or Chiari network. So here we have this kind of lasso-like structure in the right atrium, as you can see on the transthoracic. And we see this is a Chiari network. So quite common, 1% of the population, not usually significant. You can get thrombus or entrapment of pacing leads. Here's another little abnormality in the base of the right atrium. It's not really abnormality, but sometimes we see that. And this is a crista terminalis, a smooth fibromuscular ridge which traverses the atrium from the junction of the superior vena cava. So those are normal variants. Sometimes as we have an aging population, we see more mitral annular calcification. So this is caseous mitral annular calcification, and we see it's ruptured. You see on the middle image, this has ruptured, and when you go to surgery, it's like cheese-like caseous material. Let's move on to the main topic, which is cardiac tumours. So if we think about cardiac tumours, we have primary or secondary tumours. Primary can be benign things such as myxomas, fibroblastomas, lipomas, fibromas. Malignant, generally sarcomas or lymphoma. And metastatic deposits, commonly due to breast or renal or melanoma. And the location of a particular mass can give you a good clue to what it is. So if we look at the heart and we go around the heart, we can get a good idea of what something may be. So in the right atrium, lipomas, angiosarcomas are common. Interatrial septum, lipomatous hypertrophy, pericardial cyst and pericardium. In the ventricle, fibromas, lipomas. Going on to the top left, the left atrium, myxoma, again, lipoma. We've seen a picture of a calcified amorphous tumor of the mitral annulus. And on the valves, you've got fibroblastomas, lambus excrescens, blood cysts. So just the location can give you a pretty good idea of what something might be. So here we've got our first case. So this is obviously a mass in the left atrium, which is causing inflow obstruction and significant mitral regurgitation. This patient had a TOE. We can see on the intra-atrial septum on the bottom right, this is a myxoma. And you can see it nicely on the TOE and the transthoracic pictures. Obviously, the left atrium is the most common, but we can also get right atrial myxomas. In fact, you get myxomas in any part of the heart. Again, here you see it on the TOE on the right atrial side. You see it nicely on the 3D with the attachment as well. So myxomas are probably the most common benign tumor that we see, most in the left atrium, but they can occur anywhere. Sporadic, although there is autosomal dominant condition associated with them. Most asymptomatic. But the problem here is that they can cause stroke, they can cause mitral valve obstruction. So in general, you'd want that to be removed. And if you do remove them, there's a small risk of recurrence. So about 7% over 10 years. So they do need follow-up. Here's a case of a 57-year-old, multiple TIAs. So he went to TIA clinic, 4 TIAs over a week. ECG is normal sinus rhythm. He recovered obviously completely from those. This is his transthoracic echo. You see on the top left a round mass attached to the chordae of the mitral valve. And on the bottom right, you see on the aortic valve, there's also a little round mass. This is the TOE. And here we actually see there are multiple masses on the chordae. There's probably 2 or 3 on the mitral valve, and you see one on the aortic valve. It's just a 3D of it. And we removed this, and you see this is a fibrillostoma. And you see the fronds of the fibrillostoma on the histology. So fibrostomas commonly occur in the aortic or mitral valve, and obviously the risk, most are asymptomatic. The risk is they can embolize and cause a stroke or myocardial infarction. And you've just seen the typical pictures. CT and MR are not useful in this circumstance due to the low temporal resolution. So you might put them through the MR scanner, and they not pick this up. In terms of where they are, obviously they're commonly on the left side, but the size varies depending. So on the tricuspid valve, you see on the graph on the top right, they tend to be bigger than on the aortic or mitral valve. And there's a risk of stroke. So over 5 years, your risk of stroke is about 10%, so a couple of percent per year. So if you have a large fibrillostoma and you're asymptomatic, generally you'd remove these if the patient's fit for surgery. Here's another case, 52-year-old, fatigue and shortness of breath, transferred to removal of a right atrial tumor. This is an echo origin, so people know that if you look at the intra-atrial septum there's lipomatous hypertrophy. You can see on the intra-atrial septum. But here, it spreads round into the right atrium, so you see that mass at the base of the right atrium. You can see it nicely there on the bottom right picture. So it's lipomatous hypertrophy of the intra-atrial septum, and there's basically a lipoma at the base of the right atrium. So lipomas are well-circumscribed masses of mature adipocytes, very slow-growing. Normally, they don't cause any symptoms at all, but they can do if they become very large. And resection is very, very rare, but you can do that for symptomatic patients. And you can nicely see them on CT or MR, looking at the fat and comparing. Here's another case, 42-year-old, chest pain and palpitations. So we see it from the parasternal long-axis view. There's pericardial effusion, which is your first clue that there's something wrong with this patient. You can't see much else on that. Here's the apical 4-chamber view. So you see that pericardial effusion, then where the red arrow is in the myocardium, you see there's an interruption in the myocardium. You see myocardium, then when you get to the base there's a bit where you can't really see any myocardium. It's quite subtle, but yeah, it's noticeable. The same on the 3-chamber view when it plays. You see the pericardial effusion, and just next to the pericardial effusion where the red arrow is, there's a bit of interruption of the myocardium. They went after the CT and MR, which basically shows the same thing. You can see this mass. And they had it resected because they were symptomatic, and you've got tumor next to the cardiac myocyte. And this is a fibroma. And if you think about that diagram we had at the beginning, it's in the ventricle, so it's one of the most likely things, well, one of the things you could find. So these are the second most common primary cardiac tumor of childhood, often in the ventricular septum, well circumscribed. They interdigitate into the nearby myocardium. That's why you get that echo appearance when you saw it. MR is very useful, as we've seen, and surgical resection if symptomatic. So if we look at all the studies we've seen so far, and we think about how do we know if something's malignant or if it's a tumor, this is quite useful. I'll show a slightly better picture in a second. Does it infiltrate the wall? Is it polylobulate? Is there pericardial effusion? Is it sessile? Is it homogeneous or not? Is it non-left-sided? Because those are kind of things which would strike to say this may mean this is more malignant rather than benign. So here's a schema which shows at the top benign tumor, what they call pseudotumor in the middle, and malignance at the bottom. And if you look at each of those characteristics, where there's non-left localization, pericardial effusion, infiltration, polylobate shape, inhomogeneous or sessile, you see malignant tumors are more likely to have more of those. So when you see those characteristics, it kind of help you. So that if you take the location plus those characteristics, it kind of helps you determine what a particular mass is. Let's move on to primary malignancies. So rare, 34 cases per 100 million. Sarcoma is the most common. The graph on the top right shows how the incidence has changed over time. So as you see, for each of those, lymphoma, sarcoma, the incidence has increased over decades. But unfortunately and sadly, the prognosis has not. So on the bottom right of the screen, you see the prognosis over time from 1970s to 1990s and 2000s. So it's still a very poor survival, 20% about 5 years. Here's the case. 72-year-old with atrial fibrillation, pacemaker, shorter breath. Parasternal long axis images. We see this abnormal motion of the septum. And we see on the top right, in the right atrium, there's a mass. Not quite infiltrating, but we see a mass there. Seen on TTE. We see it's not homogeneous, it's polylobate. We see on the PET scan, it lights up, so it has uptake. Had a biopsy, and this is a B-cell lymphoma. They have CHOP-R chemotherapy, 6 cycles, and this is the echo after 6 cycles, completely resolved. And as you see on the PET scan, it's also resolved. So lymphomas are rare, predominantly B-cell, 3-to-1 male to female predominance, and they often occur with right-sided heart failure, arrhythmia, tamponade. And the thing that it tells you is most likely is malignancy is this infiltrative pattern crossing tissue planes, and it will enhance with contrast. And this is another right atrial mass. Here, it's still in the right atrium, but you see it involves the tricuspid valve. It's not renal cell carcinoma, as the IVC is all clear. And you see it's invaded into the pericardium. So this is angiosarcoma. Aggressive neoplasm often occurs in the right atrium near the atrioventricular groove, invades the tricuspid valve, IVC, and pericardium. Most asymptomatic, but can present with right heart failure. Let's move on to secondary metastatic tumors, commonly for breast, renal, melanoma. Can get to the heart via direct extension or spread with the lymphatic system. Echo can identify the tumor deposit, but obviously you need a staging CT plus or minus MR if you want to look further. So this is again, right atrial mass. We see it obstructing the tricuspid valve. And when we move on to our subcostal views, we can see that the mass, or mass and thrombus, is coming up the IVC. And it's not homogeneous. We can see when we look at the mass. So this is likely to be malignant. And this is renal cell carcinoma. So 3% of all malignancies. Cardiac involvement is actually relatively common and associated with coagulopathy, so you get IVC thrombus, and the extension of the tumor grows up the IVC into the right atrium. Metastatic melanoma. So this is, I didn't realize this till I did this talk, but actually in autopsy study, 50% of people with metastatic melanoma have cardiac metastases. And this is highly vascular. So if you give contrast, as you can see here, it will uptake contrast, and that will help you identify whether this is a mass in the apex or thrombus. And talk about contrast for a second. If you give a lot of contrast, you can get a false positive because of all the contrast around the mass. It can feel like there's uptake in the mass, but there isn't. So what you need to do is use a continuous infusion of contrast and assess perfusion. You see uptake of the microbubbles within the mass is vascular. If there's no uptake, it's likely to be thrombus, and you assess replenishment. And this is how you do it. So you have a mass. You see there's uptake of tumor of contrast into the tumor. You perform a flash. It destroys the microbubbles, and then you see replenishment. And I've made some stills here. So on the top left, you see contrast in the mass. Flash, destruction of the microbubbles. So on the bottom left, you see all the microbubbles have disappeared. And then you see replenishment within a few cycles. So that shows it's vascular. So I'm going to conclude that echocardiography is a primary diagnostic modality. We can identify the size, location, morphology, and hemodynamic consequence of a tumor. We can use the features we described to differentiate between normal variants, artifacts, benign, and likely malignant tumors. And we can use contrast to assess vascularity in 3D to look at extension origin, and PET, CT, and CMR complementary. Thank you for listening.
Wonderful, thank you, Sanjeev. I think in the interest of time, we're going to defer questions to the end of the session. There is the Slido app available. I don't know if there's a QR code. Maybe we could have that at some point. But it's down as BSEcho 2025, and we're plenary 1. So if anyone wanted to put their questions on that. Right, so now we're moving on. We've got Dr. Lynne Williams, who's a consultant cardiologist in Papworth, Cambridge. And Lynne has a plethora of interests, just anything that's good in the heart, as far as I can tell, looking at her list. But really importantly for Lynne, this is her last hurrah before the gritty reality of being the co-chair of vegetation arrives, I understand, tomorrow, not today. Monday.
One
okay.
more day of
So
freedom.
she's going to be smiling today, and we look forward to your talk.
Okay, thank you very much. Hopefully everyone's had their coffee and no one's feeling queasy after last night, because there's some lovely images coming up. So I'm going to talk about endocarditis. So endocarditis, as we know, is characterized by inflammation of the endocardium or foreign material in the heart. And it's most typically bacterial, but there are cases that are not. We've seen an increase in the number of cases of endocarditis over the past few decades. This is in part due to an aging, multi-comorbid population, but also because we are now putting in lots more transcatheter devices, implanting lots of devices. Now, echo remains integral and the principal imaging modality in the diagnosis and management of these patients, but particularly for device-related infections, we're increasingly appreciating the role of cardiac CT and PET scanning. And echo not only helps us to make the diagnosis, but also identify those patients with complications at risk of requiring earlier surgery. So in this talk, we're going to just take an overview of the clinical presentation and the types of endocarditis. We're going to go through our echocardiographic approach and really get familiar with the echocardiographic appearances of complications of endocarditis. So if we think of endocarditis broadly in 3 categories, we have the infective, native, or prosthetic valve endocarditis, which tends to occur in high-risk populations with underlying cardiac or structural abnormalities. So we're thinking about unrepaired congenital heart defects, bicuspid valves, or patients with degenerative valvular disease or prosthetic material in situ. Then we have non-bacterial thrombotic endocarditis, where we see this in patients usually with underlying autoimmune or hematological conditions such as lupus, antiphospholipid syndrome, or morantic endocarditis in patients with cancer. But increasingly, we're seeing the rise of cardiac device-related infections. This can be infection either on the generator or the pocket, or can extend to the leads and the right-sided heart valves. We know that the risk of infection increases with the complexity of the implanted device, with the number of repeat procedures, be that lead revision or generator changes, and also in patients who develop hematomas after procedures. How do patients present with endocarditis? Well, most typically, they will have systemic symptoms. They will have malaise, fever, chills. They may have muscle and joint pain or unexplained weight loss. But some patients present initially with an embolic complication, be that an embolus to the brain and a stroke, or an embolus to one of the abdominal organs. With right-sided endocarditis, of course, it may be a pulmonary embolus. And then occasionally patients will present with a cardiac instability. So the valvular destruction leads to acute valvular insufficiency, and they present in heart failure. How do we diagnose endocarditis? Well, we use the modified criteria that is made up of major and minor criteria. And as you can see, the major criteria are demonstration of a causative organism on 2 separate blood cultures and imaging findings consistent with the diagnosis of endocarditis. Minor criteria may be a patient who has a predisposing condition, fever, evidence of embolism, and there are some other minor criteria. So when we approach imaging in a patient with suspected endocarditis, we're really thinking of 2 things. We're thinking of the cardiac imaging to confirm the presence of endocarditis, to assess cardiac structure and function, and to plan treatment. and that is predominantly echo, but increasingly, as I said, with devices implanted, this may take the form of CT and PET, and we will often use CT to assess the coronary arteries before surgery. But it's important that we also remember that there is non-cardiac imaging, and this may be CT to identify the underlying source of infection, or CT and MRI to assess evidence of embolism, be that in the brain, evidence of discitis in the spine, or embolism to the spleen or the kidneys. So what is the role of echocardiography in endocarditis? Well, it really is the starting point, and that starting point is transthoracic, and we should be performing a transthoracic echocardiogram in any patient with a suspicion of endocarditis. We should also perform a transthoracic echocardiogram in patients who have bacteremias with high-risk organisms such as Staph aureus, Enterococcus faecalis. TOE should be performed whenever our transthoracic is negative or inconclusive and we have a high clinical suspicion. TOE should absolutely be performed when we have an implanted device or prosthetic material. And frankly, we should really do TOE in all left-sided endocarditis. And the only time we probably don't need to is isolated right-sided endocarditis, where our transthoracic imaging is of very high quality. But really, we should use TOE widely. During treatment, when would we be repeating imaging? It's very important that if there is any change in the clinical status of the patient or any suggestion of a complication, we should re-image both with transthoracic and TOE. So that may be a new murmur, new AV block, new heart failure, a clinical embolic event, or if the patient has persistent fever and positive blood cultures. So let's get to the interesting bit now and look at some images. So what are we expecting to see in a patient with endocarditis? Well, the hallmark is that of a vegetation, a mobile structure, independently mobile of the valve, attached to the upstream surface of the valve, so the left atrial side in the mitral valve, as we see on the top images, the LVOT side of the aortic valve, as we see in the bottom images. Acute vegetations tend to have a soft, homogeneous texture and irregular shape, and as vegetations heal, they become more echogenic. We're also looking for the impact of that vegetation and that infection on valvular function, and we know that we can see varying degrees of valve destruction, typically causing significant regurgitation. In the top image, we can see severe mitral regurgitation related to this vegetation, and on the lower image, severe aortic regurgitation. If vegetations are bulky, there can be a stenotic component as well. This is a TOE of a patient who presented with symptoms of feeling generally unwell and weight loss and fevers. Were found to have Staph aureus. And here we see a vegetation on the left atrial side, which is attached at the base of the leaflet, quite close to the annulus. And we've made some measurements. This vegetation measured around 1 by 2 centimeters. So this is a vegetation that would carry significant embolic risk. And this is another patient, a quite unfortunate case of a young patient with previous AVR and MVR, who'd also had a pericardial patch reconstruction between the aortic and the mitral valve, and he presented systemically unwell, features of endocarditis. We see this soft, homogeneous mass on the mitral valve, but what we also see is some abnormal flow in the bottom right image between the LVOT and the left atrium, where the patch tissue has actually been destroyed and partially dehisced. And the bulk of this vegetation actually led to an element of mitral stenosis with a mean gradient of 11. So complications, it's very important not only to assess the presence of the vegetation and the valvular destruction, but also to look for other complications that may change the surgical timing or decision making. And probably the most common one that we will see is that of aortic root abscesses. This is a native valve. This is a native bicuspid valve. Interesting, so root abscesses are more common in the aortic than the mitral position and are actually more common in bicuspid compared with tri-leaflet aortic valves. Interestingly, the vegetation on the valve leaflets has no correlation with the risk of developing an abscess formation, and most commonly the abscess forms under the left and the non-coronary cusp in native aortic valves. Typically, we see this thickening around the aortic root and then the development of areas of echolucency. This is an aortic root abscess on a prosthetic valve. We can appreciate from the transthoracic images on the top that there is a vegetation on the valve. It's quite difficult to get really clear imaging of the aortic root, but there is this suspicion of echolucency around the aorta, and we see significant aortic regurgitation in our 5-chamber view. We then did a TOE and have confirmed the presence of not only large bulky vegetations on the valve, but also a root abscess with areas of thickening and echolucency. In prosthetic valves, the infection tends to be more circumferential around the sewing ring. Root abscesses are more common with bioprosthetic than mechanical aortic valves. And this is the reason for TOE, that the sensitivity of TOE for detecting root abscesses is much better than transthoracic echocardiogram. This is a case of valve dehiscence. So if the infection is particularly destructive and you get dehiscence of the valve of more than 40% of the circumference, you will start to see this appearance of valve rocking. Quite a frightening, nausea-inducing feeling when you're in the echo lab. And typically you will see flow around the sewing ring. And on the bottom right image, you can see that that 5-chamber looks very abnormal. That tells you that this valve is not sitting well, and you see significant aortic regurgitation. Leaflet perforation, that can occur in around 15% of cases. It's quite difficult to diagnose this very accurately on TTE, much easier to see on TOE. And if we look at the bottom images of the transthoracic, we can see that there's very bulky vegetation on this mitral valve. There is also thickening around the aortic root. And in the middle lower image, you can see that defect in the valve leaflet. And also on color flow, you see the flow convergence over the body of the leaflet rather than at the coaptation zone. And you see this color coming through this perforated anterior mitral valve leaflet. In patients with aortic valve endocarditis, you can get this seeding of infection back onto the anterior mitral valve, either because of vegetations which are actually making contact with the valve, or the AR jet actually streaming bacteria onto the mitral. Embolism, this occurs more frequently than we would expect. It can be silent, so when we perform CT scans on these patients, we often find all sorts of embolic phenomena that clinically weren't apparent. But of course, embolism can be the first presentation, particularly stroke. The risk is highest in the early days after commencing antibiotic, and then starts to decrease gradually over the next few weeks of treatment. Bulky vegetations over 10 millimeters on the left-sided valve and very mobile lesions carry a significant risk of embolization, and so this may alter the timing of surgery, but really the benefit of surgery is in those early few days when the embolic risk is highest. In terms of where does left-sided valve embolize to, it's most commonly the brain or the spleen. And on the top image, we see a patient with multiple splenic lesions and abscesses from enterococcus infection of his prosthetic aortic valve. But we can also see embolic infarcts in the brain and mycotic aneurysm formation. Identifying an embolism to the brain will have an impact on surgical decision and timing because of the risk of hemorrhagic transformation on bypass. So it is important to image these patients. The last complication to go through is, we've shown this image earlier, so this is the gentleman who'd had AVR, MVR, and pericardial patch reconstruction of the aorta mitral continuity, called the commando procedure. He'd previously had his valve surgery for radiation-induced valvular disease. He'd had high-dose mantle radiation for lymphoma when he was younger. He then represented with clinical signs and symptoms of endocarditis, and we found infection not only around the aortic root, but vegetations on the mitral valve, and this dehiscence or perforation through the patch with fistulous flow from the left atrium to the, from the LVOT to the left atrium, and he had a staph epidermidis infection. Just a quick mention about non-bacterial thrombotic endocarditis. As I said, this is often in patients with underlying autoimmune or hematological conditions. It's quite rare. Stroke can be a prominent presentation of this. The vegetations are typically located along the leaflet edge at the coaptation line of the valve. It's quite unusual for them to cause any significant valvular destruction or dysfunction, and far more commonly affect the mitral. Again, TOE has a higher sensitivity and specificity, and the treatment is of the underlying condition. And this is a lady who recently came through our service. She presented initially with chest pain and was found to have myocarditis, but she was also noted to have moderate mitral regurgitation. She was worked up through our valve service, had a TOE, and this was the finding on the day of her outpatient TOE. She was admitted. There were no signs of infection. Blood cultures have consistently been negative, but she has tested positive for triple positive on an antibody screen for antiphospholipid syndrome. Just a brief mention about device infection. If there are large vegetations on the leads, then echocardiography can be good at diagnosing this. TOE is better because we're able to visualize more of the leads on TOE, particularly from the SVC. So we should perform TOE on all of these patients. CT can help us diagnose septic emboli to the lungs, and PET-CT can be particularly useful for imaging pocket infections and lead infections. So really we should have a low threshold for other imaging modalities. So hopefully I've convinced you that echo should be the first-line imaging modality in all patients with endocarditis, and that really should be transthoracic and TOE in virtually all cases, but we need to be mindful that there is a role for other imaging, for root abscesses, for certainly for device infection, and we have to be mindful of what echo can do and where we have limitations and need to get the help of our other imaging colleagues. Thank you.
Thanks, Lynn. My goodness me, stark reminder that we need to keep our antibiotics working with careful stewardship. So we're going to move on now to introduce Becky Lawton. This is Becky's debut visit, the main stage of the BSE. So I know you're going to give her a warm welcome. Becky is a clinical scientist at James Cook Hospital, and she recently published an article in Echo on the subject on which she's going to talk, which I recommend to you. It's an excellent article. Becky.
Thank you so much for the introduction. So as mentioned, I'm from James Cook, which is one of 2 adult Pectus centres in the country, and I'm going to just give you a brief overview of the condition, the cardiac abnormalities we are seeing in this patient cohort, and then some treatment options. So Pectus, Pectus for short, but Pectus excavatum is the most common congenital chest wall abnormality. It affects about 1 in 400 people, and abnormal cartilage growth causes the posterior depression of the sternum. So it's characterized by sunken breastbone and ribs. It is more prevalent in males, so it's 3 times more common in males than it is in females. And you can see from the diagram there a typical chest at the top, and then a depiction of a chest with pectus at the bottom, and you can see the compression and displacement of the heart over into the left hemithorax. So although it may be present at birth, it may become worse over time, so that might be during childhood, puberty, or even into adulthood. And you can see an image there of somebody with quite a severe form of pectus. So as with many congenital conditions, there are some associated conditions you should be aware of, especially if you're assessing via echo. And it's just to be mindful to look out for the complications that I'm going to show you, but also for the ones that are associated to things like Marfan's and Noonan's. So in milder forms, there may be only psychological concerns around self-esteem, anxiety over body image. Lots of the patients that we are seeing in our clinics really struggle in situations where they need to be topless or have their tops off, and it's a real concern for them. As the severity worsens or under strain, sometimes they may experience physical symptoms alongside the psychological symptoms, and I've just listed a few on the screen there. So what causes these symptoms? Well, it's the depression and displacement of the heart. I will talk through some of these, but they'll be better explained with some echo images. So the mechanical compression can limit the filling of the heart, and this reduces cardiac output. So patients complain of things like breathlessness and reduced exercise tolerance. Mitral and tricuspid valve insufficiency can also contribute to these symptoms. And mitral valve prolapse is found in approximately 20 to 50% of patients with Pectus. Now, sometimes that's due to the mechanical compression causing the mitral valve prolapse, but sometimes it's associated with genetic conditions such as Marfan's that I touched upon earlier. If the compression is at the right atrium or at the RV groove, you can end up with quite a small right atrium, a squashed compressed right atrium, or tricuspid annulus. If the depression is more over the right ventricle itself, you can have small linear RV measures, often in the RVOT, but sometimes you see these in the apical 4 chamber window, if you can get an apical window. Even though you have these small linear measures, the compression and distortion of the right ventricle by the sunken breastbone can actually cause overall dilatation, so you end up with dilated RV by end diastolic areas. And then obviously we see a plethora of functional abnormalities as well. You can see that the main focus here is on the right heart, and that's because it is the most anterior portion of the heart, so it's directly underneath that depressed sternum, but you can get abnormalities of the left side as well. So let's look at these in practice. So I'll talk you through them as I would find them when I'm scanning. So I would start with my parasternal long axis window, and you can see from the moving image there where the red arrow is how small that RVOT is. The linear measure is tiny. If you rotate your probe round to the short axis window, you can also see how small the RVOT is here. And in this patient example, the RVOT measured 0.9 centimetres, which is significantly lower than the lower limit of normal as outlined from the BSE guidelines. If we move more down to the mid-level in the parasternal short axis window, you can see from the still image on the left there the compression of the right ventricle, but I think it's highlighted further with the addition of the collar box. You can see there how turbulent the flow is through the right ventricle due to the compression from the pectus deformity. Whilst we're in the short axis window, another really useful tool in this patient group is calculating the eccentricity index. So in very severe patients, this can be abnormal at end diastole and end systole, but in lots of our severe patients, it's just abnormal at end diastole. So we've calculated the eccentricity index here at end diastole, and it actually measures 1.7, which you know is abnormal. And this is something that we are seeing quite frequently in this patient group. Whilst we're in the parasternal windows, we can actually take advantage of some positional measurements. So lots of patients become symptomatic depending on their posture. So what we're doing is we are measuring patients with them laid flat, then we're sitting them up and measuring the RVOT VTI, and then we're getting them to lean all the way forward and measuring it again. And Dr. Pandya actually mentioned how important positional echo was at the Pectus Symposium in London earlier this year. And because we are a Pectus centre, we've reached out to experts in the field, and the Mayo Clinic over in Arizona routinely adopt these measurements. And so as part of our routine practice, this is something that we usually do. So the normal range for an RVOT in the literature is about, an RVOT VTI is about 17 centimetres. So this might be about 17 centimetres in the Pectus patient when they're laid down, but when they start sitting up and leaning forward, we can see this drop. So naturally, if you or I stand up or sit up, gravity will kick in, there'll be less venous return, and naturally there'll be a slight reduction in stroke volume, but this is really exacerbated in this patient group for some of the patients. So I'll just show you a quick example here. So this was with the patient laid flat. The VTI, you can see there, is 13.6, which is below the normal limit anyway. When they sat up, this dropped to just over 11 centimetres. And when they leaned all the way forward, it actually dropped to just below 9 centimetres. And the patient became quite dizzy when she leaned forward. So you'd be mindful if you are going to make these types of measurements that it can bring on symptoms as well. So next, from the parasternal windows, I would move around to the apical windows. These are notoriously difficult to get in Pectus patients. If you've ever scanned anyone with quite a severe Pectus deformity, it's a really tricky window to get. I tend to find if you roll the patient all the way on the side, almost so that they're leaning forward, use a really lateral window and come down a rib space, you can often find a nice window. You can see from this move-in clip here that the tricuspid annulus is really small. You can barely see the right atrium because it's so compressed, and you could argue that the RV function looks completely abnormal. When we go to the RV focus view, you can see the still image with the small tricuspid annulus on the top there, and then on the moving image on the bottom, even though we've really tried to open up that right ventricle, that tricuspid annulus is still really small. At end diastole, we measured it in accordance to the BSE guidelines, and it only measured 13 millimetres, so that's quite a lot smaller than the normal range outlined in the guidelines of 23 to 33 millimetres. This patient also had small RV linear measures, a reduced fractional area change, and a small right atrium. There is evidence that tricuspid annulus size is directly related to cardiac function, and it was no surprise that when this patient went for their CPET testing, they actually became pre-syncopal and couldn't complete the test. So this is a really useful measurement in these patients. The other thing that example had was abnormal RV diastology, and I didn't show the examples because I just want to talk through the most common findings we're seeing at James Cook, and this would make sense if the heart is trying to relax, especially that right ventricle, against that depressed sternum. You are obviously going to find some abnormal RV diastolic parameters. The ones in the table there are just the most common ones that we are seeing. So a reduced tricuspid E velocity indicates impaired RV filling, which would make sense. An E to A ratio of less than 0.8, or a prolonged tricuspid valve deceleration time would indicate impaired RV relaxation, and the E over E prime of greater than 6 would indicate raised RA pressure. The last thing that we look at in the RV focus view is RV strain, and RV free wall deformation is the default parameter that the BSE suggests looking at. So that's the RVFWSL. The normal value is highlighted from the guidelines there, which is minus 23%. And you can see here in this example, that's well below the normal value of minus 18 there. We're seeing a lot of abnormal RV strain. This was a hot topic at the annual conference in Japan on chest wall. So where software packages allow, RV strain can give you some really useful information in this patient group. So from here, I would go down to the subcostal window. So depending on where the level of depression is of the sternum will depend if the IVC is impacted or not. If it's quite close to the RA junction, it can cause compression quite close to the right atrium, and then it can cause dilatation further upstream. So it's important to look for both factors. There's some examples on the screen there of some dilated IVCs that we found in this patient group. IVC compression can cause syncope in this cohort, so it's really important to look for this, especially if you've been unable to get some or a nice apical window. This can still give you some information about the right atrium and right ventricle if you're unable to get that. Whilst you're in the subcostal window and you've got an IVC, if you can see the hepatic vein, the S and D waves from the hepatic vein can give you some more useful information. On the left of the screen there, you can see a normal ratio, so the S wave is bigger than the D wave, giving you a ratio of greater than 1. You can see I've reduced the sweep speed here, and on average you can see the majority of the hepatic vein S waves are smaller than the D waves, so that gives us an abnormal ratio of 0.9, which would be indicative of raised RA pressure. If you've already calculated the S and the D wave, there's another really useful calculation that you can do, which is the hepatic vein systolic fill-in fraction. That's a mouthful. The calculation is actually really easy, and anything less than 55% would be abnormal. So in this particular patient, the ratio, the percentage, sorry, was 49%, which again indicates that there's raised RA pressure. So obtaining good diagnostic images and having a comprehensive echo report to go alongside this is really important in this patient group. That's because the NHS decommissioned surgery for most patients with Pectus in 2019 because there was not enough evidence for psychological and physical benefits of surgical repair. So when these patients are being discussed on the national MDT pathway, it's really crucial that we are showing them evidence of cardiac compression and showing evidence of impaired function. When I'm talking about severity, we calculate severity often using a CT scan, and it's taken into account the widest width of the rib cage and the smallest distance between the sternum and the spine there. Anything greater than 3.25 would be abnormal, and that index is called the Hallett index. The example on the screen here has a Hallett index of 5.3, so it is quite a severe case of Pectus. So briefly onto treatment options now. So some non-surgical treatment options would include vacuum bell therapy. This is suitable for younger patients, and the device, you can see that the patient's wearing on the chest there, sucks the chest wall out over time. It's quite a lengthy process. I'll show you some examples of the patient before and after wearing the device. So that was one every night for a year. And another one there. So you can see how successful that's been at pulling the chest wall out and almost correcting the deformity. Other non-invasive options would include psychological support, including cognitive behavioural therapy and counselling over those self-esteem and body anxiety issues. These are often used in conjunction with surgical or non-surgical treatment options to treat the physical symptoms as well. Silicone implants are another way to fix aesthetic concerns. So you can see from the CT scan here, what I've circled in red, they're the silicone implants. So you've got breast implants, but then in the middle, there's a silicone implant which has been placed above the dip. So from the outside, the pectus deformity doesn't look so bad, but inside, there's actually been no change between the distance between the xiphisternum there and the vertebrae. So although from the outside everything looks fixed, actually internally it hasn't changed anything. So this isn't a fix for physical symptoms. So onto the NUS repair now. So this is the most common approach to repair adult pectus. So you can see on the left here, there's quite a severe deformity there. There's barely any space between the sternum and the spine there. And you can see the insertion of the NUS bar there has just really improved the distance between the spine and the rib cage. And you can see how squashed and compressed in the pre-op image the heart is. It's completely displaced into the left hemithorax. And then the implementation of the NUS bar has just really opened up that chest cavity. So the way that the NUS procedure works is that metal bars are placed underneath the chest wall to bring it up. They're stabilised with stabiliser bars either side, left in for about 2 to 3 years, and then removed. So you can see here, there's a couple of examples of x-rays. So the patient on the left has got 2 bars with 2 stabilisers in place, and you can see on the right there's just 1 bar with a stabiliser either side. So after they've been removed at 3 years, you can see how successful the repair is at fixing the pectus deformity. So Claire kindly mentioned the article that my colleague Claire and I published last month. If you haven't seen it already, the QR code on the left will take you directly to the article. On page 34, there's more useful hints and tips on image acquisition and what you should include in an echo report. There's also links in that article, on the digital article, to the Pectus Matters charity. This is a really useful charity if you need signposting for friends, family, or patients that you may come across in the clinic. Thank you so much. I'm happy to answer any questions.
Thank you so much, Becky. Um, it's really fantastic to see the power we can do in terms of not just helping our patients, but also convincing commissioners that something which on the face of it looks correct, when we put proper evidence behind it and show a before and after, it clearly has a dramatic improvement for our patients. Now, I'm absolutely delighted to be introducing Dr. Shantanu Sengupta. Shantanu is one of the newest friends of the BSE, I like to think. He's the president-elect of the Indian Academy of Echocardiography, and I really enjoyed his talk yesterday where he convinced us of the passion that we should all have in diastolic function and the passion we should all have for exercise. And they're two things I can get on board with. So, Shantanu, I'm really looking forward to your talk again today.
Thank you so much, Tom. Thank you, Claire. Can I have my slides, please? Great. So I'm going to touch base on rheumatic valve. I'm sure you all in UK must be seeing few of this pathology. And I'm going to just make it more exciting with a lot of cases. I'm really fascinated by the cases I saw with the previous speakers. This Pectus excavator was amazing. Thank you so much. So rheumatic heart is a systemic immune condition, and it occurs as a complication of rheumatic fever. And this occurs after beta hemolytic streptococcal infection of the throat and is a problem which is there globally, mostly in the developing country. And it is a form of acquired heart disease, mostly in children and also in adults. And I'm sure there are some problems in the immigrant population also in worldwide. So now, this slide is important to understand in any valve. Why do we need echo in a valvular heart disease? So I believe that always we have to address 5 questions whenever you're doing an echo in a patient of valve, mostly rheumatic. We have to confirm the problem, the pathophysiology. We have to identify the etiology. We have to understand severity, whether it is mild, moderate, severe. Are there any other cardiac lesions? Because we get excited that we have diagnosed mitral valve problem, but you fail to see that there is also associated pulmonary valve or the tricuspid valve lesion. And what exactly we want to give the treatment. So if you want to plan an intervention, we want to have a medical management. So a good echo should always give you all this 5 information. If you're not giving this information, your echo report is incomplete. And as I understand that the valvular involvement in rheumatic is predominantly looking at the mitral valve. If you have an aortic valve, it has to go with mitral valve because isolated aortic valve is very uncommon, affected by rheumatic. A tricuspid valve can also be seen with mitral valve. You can have pulmonary arterial hypertension. And looking at involvement of rheumatic involvement of all the 4 valves is very rare. So let's start showing some cases. 13 years old boy, young boy, fever, chest pain, palpitation, joint pains, breathlessness. You get joint pains, so you start looking at the ASO-CRP, and this is the valve. And as you can see, this young boy is in sinus tachycardia, severe mitral regurgitation. You start looking at the non-coapting mitral valve. This is acute rheumatic carditis, presenting with severe mitral regurgitation. And this is an important thing that if you document, try to zoom up always, and you can look at the rheumatic nodule, a focal nodular thickening. But we don't stop at this. This boy was given the treatment of bed rest, aspirin, steroids, some ramipril, and crystalline penicillin with the focus of taking every 21 days. And he recovered, and you can see that this is the follow-up treatment. So the rheumatic severe MR goes down. So it's very important to identify this group of entity and try to treat them as early as possible. So rheumatic valvulitis is a reversible cause of acute mitral regurgitation. Echo evidence of carditis valvulitis is seen as high as almost around 45% of patients. And mitral valve is mostly involved in active rheumatic carditis. The mechanism of MR is this mostly because of ventricular dilatation, involvement of the leaflet. There can be leaflet prolapse, or you can have a subset of more than all these mechanisms. not getting this. Right. So pathological or rheumatic MR, there's a revised Jones criteria. It defines that you have to have a holosystolic jet in more than 2 views, jet length more than 2 centimeter in at least 1 view, and the peak MR velocity should be more than equal to more than 3. But of course, it doesn't reflect the severity. You should also look at the other parameters about the vena contracta and the volumes and the regurgitant orifice. You can easily look at the 3D. It is difficult to get a T in this group because these patients, kids are mostly toxic. But if you have any doubt, it's a good idea to look at the 3D T also. More images. This is an established rheumatic heart disease, which I think a lot of us are seeing. This is a female dyspnea palpitation. You can see severe mitral stenosis, and it was a pliable mitral valve. And post-BMV, you get good symptomatic relief, and you can open up a classical isolated mitral stenosis. But there is an important thing that the recent ASC guidelines, which came into 23, has redefined severe MS. Earlier it was less than 1 centimeter square, but now we have gone to 1.5 and below. So I'm just trying to show a patient. Patient was female. She didn't complain of any symptoms. She just came for a health checkup. At rest, these are the values, and we make this patient exercise. But the more important thing is these transmitral gradients go up and the PA pressures go up. So on the back side on the left side is around 21/12, and after exercising, it went to almost mean of 24 with the elevated PA pressure. So this is the recommendations, and I was a part of it, which came in 23 from the American Society of Echo, and they have redefined that anything in rheumatic MS, anything mitral valve area less than 1.5 should be, we are trying to be more inclusive to make these patients go for a PTMC and try to have a better quality of life with a mean gradient at rest of more than 10. Remember, the heart rate is very important, that their heart rate should be between 60 to 80 at the point of interrogation. Now, I'd like to just touch base about looking at the PA pressure at this point, because few guidelines are giving an idea of looking at the IVC. There are a few things where they use 2.1, but this is the guidelines which came in 2015 from the American Society of Echo from Roberto Lang's group, that they have given a 1.7 cutoff. So there is a recent work which came in JACE, which I looked at. So if you're looking at the body surface area of a person, if the BSA is more than 1.6, that means he's a tall guy, go for an IVC of 2.1. But if the BSA is less than 1.6, you should look at 1.7. So there has a lot of excitement and looking at what exactly is the size of IVC, and it also helps us in looking at the PA pressure. Moving on to one more case, this is a female breathlessness palpitation. You can see in hockey rheumatic MS. The mitral valve area was tight. She had a peak by mean of 18/12 at a heart rate of almost around 50. The mitral valve area by planimetry was 0.9. You can look at the LV function, maintaining blood pressure of 100/70. We opened it up and got a good 1.8 post-PTMC, and the gradients went down. The LV ejection fraction was 55%. But I did some work on looking at the strains of this group of patients. So it is important that the LV function assessment should be done beyond ejection fraction. And this is some work which was initiated way back, that you can have LV dysfunction in mitral stenosis because of multiple problems. There can be a restriction of tethering of the myocardium by the mitral apparatus. It can be because of decreased loading condition. There can be some right-sided, left-sided interactions. These patients can also have arrhythmias. Atrial fibrillation can cause LV dysfunction, or there can be elevated systemic overload. So we have done some work, and this is the effect of PTMC on LV strain, where we showed that even if there is an LV dysfunction, if the myocardium, if the mitral valve is pliable, it is imperative to give them a therapy of PTMC, because they have a sudden improvement of their strains post PTMC within 2 days. And the strains improve, they start feeling better, and this was a cohort of almost around 57 patients. So last case, this was a female, breathlessness, palpitation, there was no fever, and as you can see, this is a classical rheumatic hockey stick mitral stenosis, but you start looking at the aortic valve, which is also thick, very much involving both the leaflets. But the interesting part is you start looking at the other valves, and you see that the pulmonary valve is also thickened. The mitral valve area was 0.7. So whenever there is a pulmonary valve involvement with the mitral valve and with the aortic valve, it's imperative to look at the tricuspid valve also. So this is tricuspid stenosis, all 4 valves involved. You can see the doming. And the gradients mean at a heart rate of almost around 90 was almost around 5 mm. The problem is these patients are very sick. We got a 3DT, you can planimate it directly. So what is rheumatic severe stenosis is that you have to have a mean pressure gradient of more than 5 mm at a heart rate of 60 to 90. You can have an inflow VTI of more than 60. The T-half should be more than 190, and you can do a valve area either by en-face view or you can do by continuity of less than 1 centimeter square. Remember that there can be supportive evidence. So these patients need a very aggressive management because they have a very poor prognosis. So cardiac involvement is a problem. It is a most important component of acute rheumatic fever. You can have echo forms an important tool. And rheumatic valvulitis should always be done. Remember, whenever you are looking at mitral stenosis, go for an ASO and CRP because it is a cause of reversible mitral regurgitation. Thank you so much.
Shantanu, thank you so much. I've got about 100 questions for you, but I'm not going to ask them now. Something we need to all be aware of is the change in our disease prevalence and patterns as our population changes, so such an important talk. Thank you. It's now my absolute pleasure to ask Jan Forster to take to the stage. Jan is pretty much synonymous with congenital heart disease. Very much one of us. Thank you, Jan.
My laptop is playing up now.
Her laptop is playing up. I will fill.
Yeah, thank you.
I will fill because Tom has asked me to remind everybody, if you want to ask a question, please use the Slido system.
Hoping this is going to play, because a moment ago it wouldn't play.
Are you happy, Jan?
Yeah, let me just...
That's BSEcho 2025 and Plenary 1, if you're lost.
I'll keep going while it's playing, because a moment ago it wouldn't work at all. So thank you for inviting me to speak today. These are the learning objectives of this session, which is actually pretty extensive to try and cover in 15 minutes. And it looks like my thing's not going to go down now. Okay. Right, I don't know why this is happening. Because it was all playing fine before.
I think while Jan's sorting her slides out, I wonder if I can ask Shantanu a question. Would that be all right?
Yeah.
Is that okay? Yeah. So my question is, what do you do with a woman that presents with mitral stenosis in labour and has never had any medical care before that point? Do you ever see that in practice?
Yeah, so it's a very important problem. So the physiology of pregnancy has to be understood that they have an increase in their blood volumes, heart rate. So I have done some work on pregnancy and these strains also. The biggest problem they go into failure is in 32 weeks or in the second stage of labor. So The mitral valve, mitral stenosis in pregnancy, if they are severe MS, it's a good idea to get a PTMC before 32 weeks, after 16 weeks, because you are going to give them some form, even if you give them the best of leads and everything, there is a possibility of radiation. So we do PTMC echo-guided without, I mean, we don't use it, I mean, of course, they're in cath lab, but we don't use any radiation. I think it is there. But I think it's important to have 32 weeks and at the time of labor. But if they are presenting later, they have a very high risk of of fetal death and also mother going to failure. Yeah.
Really, really interesting.
Yeah.
Jan, how are you doing?
We'll try again. It did just work a moment ago.
Let's go for it.
Now
Thank
it's
you,
not.
Shantanu.
Okay, I'm not quite sure. Don't know whether IT can suggest anything. I think I'll reset it, and then if we maybe just go straight into it without pausing. We'll see if it'll work. It has, of course, worked every time I've played it.
We've got plenty of time, Jan.
Right, I wonder if I could do a little question then while we're waiting.
No, don't, hang on. Let me just see.
Are you
I
gonna
don't want
do
to
it?
stop the flow again.
Is it working?
We'll see.
It is actually just like Christmas morning. No one knows what's going on.
Okay, so I'm going to keep going. So this is the
Time for
objectives
Sherry.
that we're hoping to go through in this presentation, and I'm going to demonstrate these by means of a case, if it'll play. So this is a 25-year-old gentleman who presented to his GP with breathlessness, some dizziness, and some chest pain that wasn't related to exercise. He'd come to the UK 2 years previously from Afghanistan, and there he was in the Special Forces as a commando, and he had no family history. So his GP examined him and felt he had a murmur, so he was sent for a transthoracic echo, which was performed and reported, and the adult acquired team felt that there was something that wasn't quite right on this echo. So it was discussed with our team, and we highlighted that we thought there was definitely a problem. He was seen by a senior cardiologist who found him to be in sinus rhythm with a pansystolic murmur, and discussed the possibility of having a congenital anomaly by means of interpreter with him. His English wasn't so good. And he was referred to our ACHD team for further imaging. This is his ECG, which I think you'll agree is fairly unremarkable. Remember, this is a guy that's been a high-level commando. So this is his parasternal long-axis view. Few things that obviously kind of jump out straight away. There's obviously something arising above the aorta, but also just draw your attention to the mitral valve and the subvalvular apparatus, which is really bright, and we can see the cords and the subvalvular tissue there. We can see that structure in the long axis view. We've got a still frame there and our parameters of LV dimensions. If we look with our colour flow Doppler, we can see flow coming towards the probe in that vessel that we noted in the ascending aorta. But I think you'll agree it could be quite difficult. You might even miss that in the first instance if you had your sector width quite narrow. But if we use our pulse wave Doppler, we can see we've got a low velocity diastolic flow. And at this point, we've done nothing to the scale on the colour flow mapping. It's just our normal settings. If you notice to the left of that prominent flow, you can also see there's a little bit of brightness within the septum. So whenever you're doing an echo, we keep to our minimum data sets, but we try and be systematic. And if we see something a little bit unusual, we need to try and chase that. So if we go to our parasternal inflow view, our tricuspid valve is opening nicely, tricuspid valve is normal. But again, we've got a little bit of flow, something's happening in that ventricular septum that we need to try and work out what's going on. When we come to our short axis views, we can see the aortic valve is trileaflet, it's opening nicely. And in the bottom left-hand picture, as you come a little bit above the aortic valve, again, we can see this dilated right coronary artery. When we put our colour flow on, again, we've done nothing with the scale here. We've got flow coming up and then snaking around. So a very unusual appearance of a right coronary artery. When we look at our left ventricle in cross-section, we can assess the function. We put our colour on, and again, we get this really peculiar flow within the septum that seems to be within the septum rather than going across. Again, we need to try and tell a story, work out what's going on, And if we use our pulsed wave Doppler, we can see we've got, again, low velocity diastolic flow. So this doesn't keep with a VSD or anything like that. When we go to our short axis, our high parasternal short axis view, we're looking at the pulmonary artery. We can see, if we look carefully, 2 jets of red flow coming towards us. So the top one is pulmonary incompetence. It's what we would normally expect to see. And again, we can use our pulse wave Doppler just to be certain that's what we've got at that point. But we've got this second flow that we need to try and work out what it is. And you could really easily miss this flow. Sometimes if you've got a PA that's quite prominent, you see that kind of swirling flow within the PA. So again, it could have been that. It could have been a patent duct, but the velocity doesn't really fit. Again, it's low velocity diastolic flow. And if we chase that flow, what we can see is that we've actually got an artery arising from the pulmonary artery, but with retrograde flow, so flow going in the wrong way, going into the pulmonary artery. We can look at our 4-chamber view. We've got a little bit of mitral regurgitation in this gentleman. And when we look at his strain, it's grossly abnormal. So we've got a global longitudinal strain of about -12, an EF of 47%, but marked reduction in strain within that anteroseptal region. I'm a congenital echocardiographer, so we have to go to the right heart. So when we look at the right heart, we can see these structures in that sort of AV groove, which are a little bit unusual. When we put the colour flow on, we can see some colour within that. Sometimes you catch a little bit of coronary sinus when you're looking at the right heart, but that didn't seem to be the case. And when I first saw this gentleman's echo pictures, I thought he might have a fistula that was coming into the right heart. But what doesn't keep with that is the fact that the right heart dimensions are normal, and his RV function is also normal. But if we follow that structure at the side of the heart, we can see that actually it's a serpiginous vessel that loops around and comes up towards the septum. We've got flow towards the probe. So again, I've done nothing with the scale here. This is all just normal velocity imaging. So in summary, we've got a dilated right coronary from a normal origin, but with a very tortuous course. This should be a massive red flag. If ever you see one coronary artery dilated, always worry about the other one. So those were our pictures we had of the right. We haven't really seen the left coronary coming easily from the left sinus, and what we've seen is a vessel coming from the pulmonary artery, which again looks dilated and tortuous. And we can see that if we just let that play. So again, we've got this flow, retrograde flow, coming into this pulmonary artery. So a really, really unusual appearance. And when we see this flow, this makes us think we've got an L kappa, so an anomalous left coronary artery arising from the pulmonary artery. We've seen all that prominent flow in the ventricular septum, and that's related to collaterals, and also we've got some LV dysfunction. So this patient also went on to have a CT scan, which showed the same as the echo. So we had a large tortuous right coronary that came from the right sinus. No origin of a coronary artery was seen from the left sinus. That right coronary was dominant, it was tortuous throughout its course and gave rise to the posterior descending, and then connected to the distal circumflex and connected into the left coronary artery system. The left coronary artery was found to arise from that pulmonary artery. So we've got an anomalous left coronary artery from the pulmonary artery, so a really unusual condition. So we call this an L kappa because it's not so much of a mouthful, not to be confused with an alpaca. So if we look at our CT imaging, these are just some still frames so you can try and get your head around these pictures. We can see with the star the right coronary artery, so this big vessel that comes up and snakes around. And in the right-hand images, we can see this vessel marked with the triangle, which shows the left coronary artery coursing up and again taking that sort of tortuous route. This particular case, the pulmonary artery, the coronary artery is very posterior to the PA, so it can be really quite hard to see these vessels. I'm going to let this cine run in a moment, just to show you the sort of the complementary CT imaging. So this is the aorta, this is the pulmonary artery, and we're going to keep our eye on this area first of all. If I just let this run, she says, hopefully. So we've got the left coronary artery coming here, the right coronary artery came up here, snakes all the way round, and then comes back up through the septum. So if we go again, we've got the left coronary coming here, right coronary coming here, and then snaking all the way up through that septum. So a really nice demonstration of that pathology, which confirms what we've seen on the echo. So what is an L kappa? It might be something you've not particularly come across before. It's a very rare congenital abnormality. It normally presents in childhood in the first year of life, and we should always consider it in patients who present with a dilated cardiomyopathy, LV dysfunction, or mitral valve dysfunction. When we have the situation where the left coronary arises from the pulmonary artery, the changes that occur at birth mean that actually we get these collateral vessels that develop between the two coronary systems. And we get this phenomenon called coronary steal, which occurs, where essentially, because the pressure is higher in the aorta, the blood flows along the pressure gradient. And so we have retrograde flow that comes into the pulmonary artery, which obviously results in ischemia of the myocardium. This in turn leads to fibrosis. So this is our normal situation on the left. We can see our normal coronary origins. And on the right, we can see this left coronary artery, in this case, arising from the pulmonary trunk. In childhood, children will normally present with kind of a little bit non-specific symptoms. So poor feeding, poor weight gain, very sort of non-specific things, really. Generally, just parents feel things aren't quite right. And when we have this situation, it's associated with really high mortality if we don't treat it. But just as all of congenital heart disease, any of the conditions that we see are a spectrum, and we can see these things later in life, as we have for this gentleman for the first time when he's come for his murmur query cause echo. So it can occur at any age, so always be vigilant. They'll frequently have sort of non-specific symptoms. Remember, this guy was a commando, so unbelievable that he's achieved that level of activity, really, through his life. Often in these patients, the first presentation will be arrhythmia because of that fibrosis, and we know that sudden cardiac death may be the first presentation and accounts for up to 9% of sudden cardiac death in athletic adolescents and about 1% in non-athletic adolescents. What's kept this patient going is all of those collaterals that have actually been connecting the systems together. Just wanted to show you how an L kappa would usually present. So this is a child who's presented in the first few months of life, and their ventricle is the same size as an adult ventricle. So this ventricle is kind of 4 or 5 centimetres. You can see that brightness of the subvalvular apparatus, and this very prominent right coronary artery is the flag that we've got LV dysfunction, a big right coronary. There must be something. Where's the left coronary? And we can see in the bottom right-hand picture, again, we've got this left coronary artery coming off the pulmonary artery with retrograde flow into it. This is the more usual position that we normally see an L kappa in, rather than that very posterior presentation in this gentleman. So how are we going to assess these patients on echo? So normally this high parasternal short axis view with sort of subtle angulations, you have to work, you have to try and find these vessels. It can be quite a challenge. So if ever you see that dilated right coronary, think about where is the left. You can also have an R kappa where the right coronary artery arises from the pulmonary artery, which is even rarer. So always be mindful that there are lots of different anomalies that can occur. You need to work really hard to find that true origin sometimes. So use all the functions that you've got available to you. Cine and freeze are actually really useful. So just freeze it, loop through, and you have to see that coronary artery coming into the aorta. I personally would always look at one and then the other. Don't try and just do a dynamic clip where you can see both of them. You have to pay attention to each origin in turn. And colour Doppler can be really helpful. In general, we'd normally reduce the colour scale, but in this gentleman, we didn't need to. Oh, and now it's going to stop again. Fabulous. Oh, here we go. Oh, no, sorry, I was a bit too quick on the thingy. There we go. So how are we going to treat these patients? So in this gentleman, what happened was his left coronary artery was removed from his pulmonary artery and re-implanted onto his aorta. Sometimes we might do a tunnel sort of from the aorta to the left coronary, or do a bypass graft. It depends on the particulars of the patient. These are the intraoperative images in this gentleman. We can see at the top here, this is his aorta, and this is this massive right coronary with collateral vessels coming off here, and even bigger in case you didn't see it. this huge, great big vessel, and then this is where the surgeons transected the aorta to start the implantation. And actually, it's always really useful to talk to your surgical colleagues to find out exactly what the procedure was. So this was a little schematic diagram our surgeon drew for me just this week, where basically this is the aorta, this is the PA, and what he's done is made an incision, opened sort of essentially 2 flap doors, closed them, and then connected it to the left coronary. So it's really useful to know exactly what the surgical technique was. As I say, there's a lot to cover in this very short presentation, so I'd like to sort of draw your attention to this paper that was published in ERP in 2024, and this goes through lots of different coronary artery anomalies. There are many different variations that we can have. Give a shout out in the audience. I think we've got Drew and Mel, so thank you for your help with this document. It was really, really great to work with you both. These are some of the things that we've gone through in this paper. So we've looked at anomalies of the origins that arise from the pulmonary artery, from the aorta, anomalies of course, and other anomalies. So there's loads of different variations, and it's not something that we're necessarily familiar with. We can't assess any of this if we don't know what the normal coronary artery anatomy is. So knowing what is normal is really key, and practicing getting these views is really, really important. And this isn't something that is just about screening athletic individuals. It's something we should have some knowledge of doing. Again, in this guideline document, we've talked you through exactly how to get these images and shown you the use of colour flow and shown you some normal pictures and some abnormal pictures. We've also gone through sort of our sort of tips and tricks for assessing coronary arteries. So some of it, patient position is really key. Giving yourself time to identify the ostia and the course. You have to spend some time trying to get the images that you want. You need to optimize as much as you can, make sure you've got the right transducer, the higher frequency, the better. Use a coronary preset if you've got that, and colour flow mapping can be really key. It's also really important in your report, especially if you're assessing a patient with a history of sudden cardiac death, maybe in the family, in your ICC clinics, is to actually acknowledge whether or not you've seen the coronary arteries or not. So no statement isn't really enough. You need to say coronary artery origins and course appear to arise normally, or I haven't been able to demonstrate them. So you need to acknowledge, there needs to be a statement to acknowledge the situation. Also draw your attention to this joint document from BSE and cardiac risk in the young. Again, this is sort of the screening guidelines as to how we assess athletes, but again, there's a coronary section within that, which is similar to some of in the other paper as well. So how was this gentleman done? So this was his echo 5 days post-op. At this point, he's just come off ICU. He's flat on his back on the bed on the ward. But actually, you can see that you can still get really good pictures of these coronary arteries, even in a suboptimal position. So he's got a pleural effusion, a little bit of pericardial fluid. We can see flow into that right coronary ostia, but it's actually bidirectional at this point, which was a little concerning, to be honest. We then go to the short axis view, and again, we can see the right coronary ostium in the top left. In the middle picture, we can see the left coronary ostium is now coming into where it should be, into that left sinus. And that collateral flow within the septum has reduced. His strain, however, had gone off even more. So this was kind of a bit of a concerning time for us. So the strain has now dropped to -7. And this is all just related to the post-bypass stunning, the sort of competition between the left and the right coronary systems at this point. His right ventricular function also went off immediately post-op, and we can still see that vessel at the side from that right coronary artery that was looping round. And again, we've got bidirectional flow in these collaterals now, and it's just while everything's kind of rebalancing. So we have to be patient. This was his 6 weeks post-op scan. So this was on Tuesday. This gentleman came back to clinic, nice and timely for the conference. And pleased to say that things are beginning to improve. So we can see that actually the function's beginning to pick up. The collateral flow in the septum is really difficult to even see now. We've got the 4-chamber view there. Again, the strain is beginning to come back up. We had also done a CT as an interim point after that post-op day 5 scan, just to make sure that there was nothing wrong with any of the connection that had been made. And it just takes a long time for these cases to recover. It does it in children, but even more so in adults. The right ventricular function, again, is beginning to come back up. And again, you can see now, this is 6 weeks post-op, we can't see any flow really in the septum of those collaterals. Those have regressed, and that's with the velocity scale right down, and we still can't see them. So things are heading in the right direction. So the learning points from this presentation are coronary assessment is not routine. It's not something that we're all familiar with, and it takes practice, but I'd encourage people to do it so that you've got those skills. Colour flow can be really helpful in helping you assess normal and abnormal pathology, and you'll probably need to use some non-standard imaging views. If you're not sure, and you're not sure what the echo is showing, ask somebody else. See if somebody else within your department has got some more experience and if they can help you with that. And complementary imaging modalities will be required, so you're going to need to have some more cross-sectional imaging. Discussion with the surgical team and the imaging team is really useful, and you need to sort of discuss the case and try and work out exactly what you're seeing and understand what the surgeon's done to help guide your echo. And never forget that congenital conditions will present for their first time in adulthood. So next time you see that referral that says murmur query cause, look out for your coronary arteries. Just like to acknowledge the congenital cardiology team back at Leeds, Karina Gopal, who's one of our ACHD consultants who's helped me with the cross-sectional imaging in this patient, and the surgical team of Mr. Ali Al-Sharif and our senior surgeon, Ms. Karen Van Dorn.
Thank you so much, Jan. I think it's a wonderful way for us to finish this session, just summarising the spirit of the BSE, taking something very complicated, breaking it down for you into clearly digestible chunks.
And finishing with a picture of a llama. We're going to let you... sorry, I apologise. Thank you so much for enjoying our Christmas box of chocolates. Tom, happy Christmas.
Happy Christmas. I think lunch is ready.